Welcome to today's MESUD Learning Community Echo, Substance Use Disorder Through a Pharmacy Lens. Today we'll be hearing from Arielle Gross on harm reduction. My name is Bethany with CCSME, and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been approved by the Maine Board of Pharmacy for 1 hour of continuing education credit. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for 1 AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. And now for a quick introduction for our presenter, Arielle Gross is the Overdose Data and Action Program Coordinator at Portland Public Health Division in Portland, Maine. In her role, she oversees the implementation of the local grant. This grant work involves supporting strategies addressing harm reduction, linkage to care services, overdose data surveillance infrastructure, as well as clinical and health system best practices. And with that, I'll hand it off to Arielle for our presentation. Thank you all for being here today.
Thank you, Bethany, and thank you all for joining and expressing interest in this topic. I will get right into things. Like Bethany mentioned, I work at Portland Public Health within the Overdose Data to Action program, and I am coming to this topic from the lens of a public health practitioner. So I'm very interested in, when we get to our discussion component of this session, hearing about your pharmacy perspective and experiences through clinical practice. Harm reduction. So many of you may be familiar with the concept of risk reduction, putting on sunscreen to protect from effects of sun damage, wearing a seatbelt while you're driving. I want to acknowledge when we are talking about harm reduction in the setting, specifically in terms of substance use, these were a set of practices that were founded within a social justice movement at the height of the war on drugs and the AIDS epidemic as a way of community members who belonged to queer community, people who use drugs, folks who are Black, Indigenous, people of color, ways of keeping themselves safe at the hands of increased incarceration they were facing during these times. In practice, harm reduction is an applied set of principles. So in doing our work as harm reductionists, our goal is to reduce negative consequences associated with use. We are not looking at moving anyone along the substance use spectrum unless they are actively expressing an interest and openness in doing so. Assessing stages of change is part of our work, and guiding a discussion rather than forcing any one way of movement. Promoting non-judgmental care. We are here to support individuals in whatever stage of use they come to us in, and help to guide those positive health outcomes for an individual. We definitely value direct input from those with living and lived experience of drug use. We want to make sure that our services we provide are reflective of the needs of our participants. With the drug landscape changing over the course of the past several decades, and even within the past few years, we've seen polysubstance use, many new drugs and derivatives coming into the supply, and we want to make sure that our programming is adaptable along with those changes in the drug use landscape. And lastly, encouraging participants we support to be the drivers in the decisions they make. So our role, again, is to offer a range of options to those individuals, and it's up to them to decide which option they are open to pursuing. We, of course, are guiding them in our expertise, but acknowledge that these individuals, people who use drugs, are experts in their lives and experiences, and we want to make sure that there is mutual buy-in in decision-making that is happening. So a little bit of rationale for harm reduction services, specifically syringe service programs. The provision of sterile supplies tends to be, I would say, the most stigmatizing aspect of harm reduction work. A criticism of, the distribution of sterile supplies often is that providing these supplies enables drug use. According to research that has studied the outcomes of syringe service program participation, We have found that participants in these programs are 3 times more likely to stop using substances than someone who's not connected to a syringe service program. In addition, participants in these programs are 5 times more likely to enter into substance use treatment than an individual who's not otherwise connected to syringe service programming. So really the distribution of supplies is an element of our programming. I'll get more into the complete span of harm reduction services that are included. But the supportive services that we provide are just as vital to programming as the supplies that we distribute in terms of encouraging positive health outcomes for individuals who participate. Another element of the reason behind why sterile supplies distribution is an aspect of harm reduction. These sterile supplies, our goal is to distribute them so that an individual only has to use a syringe or another element of those supplies a single time and is able to dispose of them. Many of you might have seen a diagram similar to this. The reason why we don't encourage repeated use of syringes or syringe sharing is that after even one use, the tip of a syringe becomes dull or barbed, which can cause increased trauma to the skin, be a site of infections at the injection site, grounds for abscesses to form. So by providing one syringe to be used a single time, this is just reducing the chance of increased trauma to the skin and bacterial exposure from repeated use. And just understanding the trends in terms of infectious disease transmission. Within the past few decades, we saw an upwards trend of HCV cases within the United States, surpassing all other nationally notifiable infectious disease conditions. So one of the aspects of our programming that I will highlight is that we offer hepatitis C and rapid HIV testing on site within our clinic as a service that individuals are able to participate in. And by, encouraging folks to know their status, being tested often, especially when there is a situation of potential syringe sharing or shared exposure, it's a chance for us to follow individuals to be connected with care. So other than sterile supplies provision, what does syringe service programming look like at Portland Public Health? I just wanted to highlight some of the broader aspects of this type of programming. So we, like I mentioned, offer HIV and hepatitis C testing on site. Results can be given within 20 minutes, and then we are able to do blood draws here in our clinic and refer individuals to additional services and treatment programs. We have several patient navigators who work with individuals to connect them to medical services in the community. This is something that is unique to our program and funded through our CDC grant. So other SSPs in the community you may be aware of might not have as robust a referral system, but we really try to utilize patient navigators as advocates in terms of connecting folks to care. We're able to support folks' basic needs in terms of acquiring personal identification, nutrition access, definitely naloxone distribution, and offering overdose prevention and response trainings. These are offered to any individual who comes in for supplies and is actively involved in responding to overdoses in the community. We offer sharps disposal. So in the same way that we are distributing supplies, we encourage participants in our program to bring those supplies back to us and dispose of them properly. We can offer immunization. So hepatitis A and B have been prevalent among our participant population experiencing homelessness. So folks who come into the program, it's another option to receive these immunizations if they haven't already. And we provide on-site wound care. In situations where these wounds may be more intense, we do direct referrals out to other healthcare services. You all may be familiar with xylazine and the necrosis that it can cause with wounds. So in those instances, those tend to be beyond our capabilities as non-certified health practitioners, and we tend to refer those out to more intensive medical care. Because we are speaking in the realm of harm reduction best practices, I just wanted to highlight that our program and many programs within Maine provide injection supplies. But there are various other routes of administration that someone who uses drugs may take. So really, when we're striving for best practice, it's offering a range of these options: smoking, snorting, booty bumping. We see that and research demonstrates that folks who are in programs where other supplies, sterile supplies, are offered for different routes of administration, an individual will change from injection-only use to using through different routes. And non-injection routes of administration lead to less risk of overdose. So that is just one element, an aspect of this supplies provision, is that we are limited currently with our programming, but ideally, being able to offer the full range of options would allow someone to participate in an additional layer of risk reduction. So for folks who have never visited a syringe exchange, I wanted to be able to include a picture of what our office looks like and some of the supplies that we provide. So for anyone in Southern Maine or around that area, we are open 5 days a week, and we also do active community outreach, distributing a range of supplies that you see here, along with sharps containers. That's the black item in the picture, to encourage folks, even if they aren't going to return to the office, to be able to dispose of their syringes properly through other channels like pharmacies in the community. So specifically, how can we apply these principles of harm reduction to pharmacy practice? There are several ways in which that pharmacists can uphold harm reduction within your settings that you are working in. The provision of overdose medication like naloxone. Now it is offered over the counter, but that is a very important element to be able to spread overdose prevention and educate more of the community to have them be bystanders and able to be involved in overdoses and overdose reversals that happen outside of our practice settings. Dispensing of syringes. So Maine state law does allow for the retail sale of syringes to individuals over the age of 18. So not only is this a site where an individual has lower barrier access to obtaining syringes, but it is also a place to encourage proper disposal of used syringes or other medications that individuals are bringing in. The filling of maintenance medications like buprenorphine, which allows a broader access to treatment for individuals other than only inpatient settings. And then an important element of this is offering resources for connection to care in the community. You know, I don't expect you all to know everything there is to know about harm reduction, but I have a few community resources to highlight here in this presentation, where if you are speaking with a patient who could benefit from increased harm reduction resources, these are very beneficial resources to refer people to. All of these practices contribute to mitigating risk for patients taking opioids or, you know, potentially other drugs used in combination. They reduce barriers to ordering requested medications and obtaining treatment through more widespread access, and create partnership in the community by building knowledge of resources that you all are aware of and that patients are aware of to be able to take advantage of. So I reflected on some of these elements in terms of the social ecological model. This acknowledges that there are many influences on health behavior than just the individual themselves. And there are several layers of pharmacy practice that reflect these different layers of influence on a person. So within this individual layer, treating patients with dignity and compassion in terms of the places that they are coming to you is something that I feel is important to uphold in practice. Protecting patient rights, of course, maintaining transparency in decision-making. So if there is a reason why a certain drug interaction is not beneficial for a patient, if there's a reason why they are being restricted from receiving whatever syringes for any reason, that is something that I would encourage to be directly communicated to the patient so that they have a full understanding of the situation. in terms of provision of health services, counseling on risk and safety strategies. So, a lay member of the public coming to purchase naloxone, while it's amazing that this is now available over the counter, it's still an opportunity to educate these community members on how to properly use naloxone and maybe places that they can report the overdoses that they're experiencing in the community. Utilizing screening tools like prescription drug monitoring programs and other tools that may help with assessment of patients for indicated opioid use or other substance use disorders. Educating patients about resources available to them, like I mentioned, connections to community care. Developing protocols for effective referral processes. So it helps to have individual relationships with providers in the community, but if it's something where your organization is able to standardize some of those referral processes to put in place for individuals who may not have that knowledge of community resources, that's something that could be universally applicable in these types of settings. And then thinking about policy in place that could expand access to harm reduction resources for individuals. The elimination of the X waiver has helped with treatment initiation and expansion in the community. And thinking about if you have noticed repeated barriers in terms of serving people who use drugs, what are ways in which at an organizational level you would be able to work towards supporting patients in that way. So here are a couple of community resources. The state has a website which lists all state certified syringe service programs for those of you who may not be familiar and would like to locate which ones are in your area. They all have varied operating hours and days of the week, so I would suggest calling ahead to verify what the most up-to-date schedule of these programs operating is in terms of referring patients over to those services. But here are the first few set of counties and the others. What's exclusive about Maine Access Points as a program is that they do offer mail-based supplies distribution. So if you are interacting with individuals who may be farther, in a more rural setting, that is an option for them to be able to obtain sterile supplies. And I do know in some of those areas that are more spread out too, being able to come and obtain supplies from the pharmacy is a very low barrier resource for folks too. This is the Options program, overdose prevention through intensive outreach, naloxone and safety. So Options has a liaison who is available in each county within Maine, and they do referrals regarding overdose prevention, harm reduction, treatment programs, recovery programming within each county. They do education on some of the items outlined here, understanding of the Good Samaritan law and people's rights if they are to interact with law enforcement or respond to overdoses. They do provide naloxone as a tier 2 distributor. I'll talk more about that system. But the great purpose of the Options liaisons is being able to work one-on-one with individuals to do similar to the work that we do as staff here at Portland Public Health, but be able to gauge where their interests are and connect them with the right resources in the community that fit their needs and goals with substance use at the time. This is, so Maine is set up with a statewide tiered naloxone distribution system. I've highlighted different areas here. If you're in Southern Maine, then Portland Public Health is your tier 1 distributor contact. The other distributors are Bangor Public Health, Maine General, and Maine Access Points for other areas of the state. Really, the way this system works is that we provide naloxone free of charge and also overdose prevention trainings to any organization who expressed interest in receiving them to be fully onboarded as a tier 2 distributor. And these are the same requirements statewide, not just for Southern Maine, which is our catchment area. We require all staff to be trained in how to use naloxone. We also provide naloxone to be distributed to patients who express need for it. And we do have an element of reporting that is involved in being onboarded as a tier 2. Really, the most important aspect of this is being able to capture distribution that happens to patients or community members that you are seeing, and also receiving overdose reversal report back. So if there are non-fatal overdoses that individuals are responding to in the community, especially if first responders aren't involved, it's a way of us collecting data around those instances, and being able to improve the education that we can provide to community members on responding to overdoses. We have trained a variety of health system settings. So if you are not sure if your organization is trained or you're interested in doing so, please feel free to reach out to me after this, and I'm happy to get you connected with the right contact in terms of receiving that training. I know I'm getting close to time, so I'll just be quick in wrapping up these slides. For those who may not be familiar with different formulations of naloxone, it is available in several different forms. The auto-injector is less common now. We're seeing many more formulations of the intranasal version. The intramuscular is still available. As part of our syringe service programming, we offer both the intranasal and intramuscular, and it really depends on the individual in terms of which formulation they end up taking. Some do like the intramuscular because it allows for titration of the dose. So when we were thinking about compassionate overdose response, our ultimate goal in an overdose emergency, and I'm sure Stephanie will speak more to this in our overdose prevention topic, but our ultimate goal is to restore breathing. We want to avoid throwing someone too far into precipitated withdrawal. So a nice aspect of the intramuscular formulation is that someone could titrate a dose if they're, very experienced in responding to overdose, to not trigger too intense precipitated withdrawal symptoms. And the same is similar with these intranasal formulations of naloxone. Revive is a formulation we'd recommend because it's lower dose. Of course, you can administer as many doses as necessary to reverse an overdose, but we are able to administer less of a dose at a time than something like Cloxato, which is an 8 milligram dose. And Narcan, is a standard middle ground to be able to use in terms of responding. So part of the reason why I wanted to highlight our overdose response within the state is that we've seen a downwards trend within 2023, and now 2024 is also mimicking that trend in fatal overdoses that have occurred in the state. In 2024, the total was 490. So, one of the positive effects that has contributed to this is bystander naloxone administrations. So in 2024, we saw an increase from 6% to 10% of bystander-only naloxone administrations in fatal overdose events. So of course, we stress the importance of involving first responders, but the more individuals and patients you see trained in the community to respond to overdoses has a positive effect.
Thank you so much, Arielle.